We are ready now for the final speaker of our day today. And in fact, our next speaker is delivering a potpourri of topics. And they're being presented by Sonic's National Director of Genetics, Professor Graeme Suthers. Now, for a little background, the purpose of Sonic Genetics is to enable the provision and promotion of genetic testing services with a goal to becoming a leader in the provision of clinically relevant genetic diagnostic services in Australia. They and we, ClinPath, are here today, are very lucky to have him in our midst because Professor Graeme Suthers is one of Australia's most respected experts in the field of genetics. With an outstanding career and deep experience in genetics, healthcare and research, Graeme is nationally and internationally recognised for his expertise in genetic disorders, testing and clinical service provision. He spent 20 years working in Adelaide, and why wouldn't you? It's wonderful. It's why I do the Adelaide Show podcast, as a medical specialist, pathologist and clinical researcher before joining Sonic Healthcare as Director of Genetics in 2014. His goal is to provide genetic services of the highest quality and utility to patients, families and managing clinicians. So I will kick us off here with a summary of what Graeme will be delivering. PGx, understanding how to improve a patient's outcome to reduce adverse reactions and improving response to medications. Carrier screening, understanding why antenatal screening for chromosome disorders improves outcomes. We'll then have a short break, and then Graeme will return on the topic of lactose intolerance, understanding why identifying lactase persistence in a person can simplify the management of intestinal symptoms. NIPT, understand challenges which may present from prenatal testing for chromosome disorders. And FH, understanding the types of patients who may well benefit from this test. Professor Graeme Suthers.
Thank you very much, Steve. Thank you, ClinPath, and thank you for your time this afternoon. I mean, with that sort of introduction, I feel that Steve must have rung my mother.
I did. She's wonderful.
She's wonderful. She thinks you are too, Steve, I'm sure. Look, in this COVID-safe environment, we've got people spread out physically here and also on the web. So hello to the Zoomies who are watching us online. I must say, I feel like a herbivore up here. Are you aware that herbivores have non-overlapping visual fields? So they can see the carnivores coming up. You're the carnivores because you've got your visual fields overlapping so you can focus up front. I really need to be a herbivore so I can get the lateral view. So if I falter in the course of the afternoon, I apologise. Okay, let's get down to business. As Steve flagged, we've got quite an eclectic mix of topics today, and it highlights that genetics is a bit like the sand at a beach picnic. It gets into everything. And that can be an irritation if you don't enjoy genetics. One of the things I've really appreciated and savoured in my professional career in genetics, it is the most general of specialties because we do get into everything and we're involved in everything from preconception issues to all the way through childhood, adult life, and then there are post-mortem issues as we in retrospect try and work things out. So that's been a very satisfying part of the journey, and it is not exclusive to geneticists. So if there's one message I would like to give you to take home from this afternoon is that you can do genetics. As with any discipline, any domain of healthcare, you need to be respectful of your professional boundaries and your knowledge boundaries and so on. But there is no need for you to say, oh, I need to leave this to the expert. Because it has to be you. We have to deliver genetics on the ground at point of care. And so my presentations today are primarily directed at empowering you to be the point of care deliverers of genetic testing to improve the care of the patients that you're looking after. So that's why we're heading where we're heading. And we're going to start by first talking about pharmacogenetics. Now, Pierre, I'm going to get my timer going on here to make sure that I don't go over time on this. We're away. Good. It's telling me that I'm over time, and since I've only just started, I thought that was a little bit unfair. I'll get on to Dr. Davis later about that. So I want to talk about pharmacogenetics today, and this is the starting point, and we have these various learning points here. I'm not going to work my way through each because you have them written down in front of you in the handouts that you've been given, but we will come back to this at the end to make sure that we have addressed these various issues. And these are here both to guide my presentation and to guide your thinking. You need to make sure that you're switching on to each of the elements of this presentation as we go through. This slide summarises the generic situation where a medication is taken into the body, which is the rectangle there. And when a medication is absorbed, various things can happen. Yes, the medication could get over to the right to sort of find some receptor or target molecule or have its point of action, but it will also, over time and via various means, be excreted. In the first step, we have here what the body does to the drug. This is the pharmacokinetic side of things, how a drug is absorbed, distributed, how it's metabolised, how it's excreted. And over on the right-hand side, we have pharmacodynamics, which is what the drug does to the body. And at this point, I'd like to emphasise that for many, perhaps most of the drugs that we're dealing with, even today, we do not know the details of the mechanistic target. We don't know exactly why they do what they do. I'd like to suggest that situation is changing and has changed quite dramatically over the last 10 to 20 years, but we don't have it nailed down. There's still quite a lot of empiricism in this space. And I do want to emphasise that this interplay of pharmacokinetics and pharmacodynamics is quite complex. And it's governed by genes. So there are going to be a myriad of genes that are potentially involved in all of this. In terms of choosing which drug you're going to prescribe and which dose you're going to prescribe for a particular patient, that's going to be informed by the response from the patient. And again, I would highlight that there's a degree of empiricism here as to actually just seeing what works on the ground. That's how much of the dosing and much of the drug selection in the past has been determined. I think that we're moving very much so to now a more intentional approach to this sort of thing, and that's a very good move, don't get me wrong, but we must remember that we are primarily interested in the empirical outcome from these interventions. I want to discuss primarily about pharmacokinetics. There is a separate part of the presentation we could do on another day about pharmacodynamics. We don't have as much information about that, but we do now have a lot of information about the pharmacokinetics, what the body does to the drug, and what exposure, therefore, the body gets to the drug. For example, if you have some genetic variant which limits the excretion of a medication, you will fairly rapidly begin to accumulate an excessive amount of the medication if you're using a standard dose. And that accumulation can increase the concentration and increase or shift the balance so that you're more likely to get an adverse effect. And so slow metabolism runs the risk of increasing the side effects or toxic effects from that particular medication. It can also go the other way around, that if in fact you have very rapid excretion so that you get rid of the drug faster than you might expect, then you may reduce the amount of drug to which the body is exposed, to the active drug, and so you're going to have less benefit. And so fast metabolism can risk the effectiveness of the medication. Now, I've presented that to you as a binary possibility. It is potentially much more complex than that because a drug may well need to be metabolized into an active metabolite before it has any action. And codeine is a classic example of that. Codeine by itself is useless. It needs to be metabolized into morphine to actually have the analgesic effect. So this slow or rapid metabolism of the drug actually has the opposite of what I've just described here. I don't want to get hung up on those details, but I simply want to flag that there are a number of ways that this can be sliced and diced for a given drug in a given patient. The way we can approach this and begin to provide you, the prescriber, with useful information is to look at a variety of genes that are involved in the pharmacokinetics, in the metabolism of a particular drug or group of drugs. And on the left-hand side here, I have the genes that we include on our sonic PGx panel, PGx being the abbreviation for pharmacogenomics. I'm sorry, it's just there. Everyone uses it. So if you hear PGx slipping out, apologies for the jargon. I'm just using that as an example. If we in fact had a complete list of all the genes that were involved in the metabolism of drugs, there are a lot of drugs to metabolise, then we would have a list that would go down off the bottom of that screen across the floor and out the window. It is huge. But what we have here are the top genes that have been identified as having very high level of evidence of clinical utility in prescribing. And there is a lot of work going on in this space month by month. They're just ballooning volumes of medical literature. And so over time, the list of the must-have pharmacogenes will increase. It is already doing that. But I'm just flagging, this is what our current repertoire of genes is. And it's not unique. There are a lot of overlap with other providers who will have a similar gene list as well. So when we analyse the genes in a particular person, we will come up with an analytical result. And that is the genotype. And there are a number of ways that can be described. Again, I'm not going to go into details, but a very common way is what they call the star allele coding, where there's an asterisk and a number, and that is shorthand for a particular variant in a particular gene. Now, if I were to give you a list of those star alleles for 10 different genes, you'd just sit there goggle-eyed and wouldn't know what to do with it. And nor would I, for that matter, because it's at a technical level which you and I don't need to interact with. It needs to be embedded there in the test process, but it's not particularly useful. It becomes more useful when we can use that genotype, that genetic analysis, to predict the activity of the corresponding enzyme, where we can say this is either a normal metabolic rate for the metabolizer for this particular gene and the substrate, the drug that it's working on, or it might be a poor metabolizer, whether there's a slow rate, or it might be a fast or indeed an ultra-rapid metabolizer. That becomes a bit more useful, but it's still fairly technical. For those who are in the know, this is the information they want to hear about. You'll hear those phrases bandied around in talks about pharmacogenomics. But in fact, what's really important to you is to get some prescribing guidance. And that's where the rubber hits the road, and we can say for this particular patient, on the basis of this genetic profile, we're going to recommend that you don't use this, or you do use that, or you modify the dose here. So it's really that final bit, which is the bit that is of relevance to you. And these principles actually look quite simple if you can step them through in that way. If only. So here we come back to the cartoon again. We have a medication that's coming in. There is some metabolic or excretory process there, and either the primary drug or its active metabolite shift over to the right-hand side to have some effect on the receptor or target molecules in the body. That's very simplistic, because the reality is that the medication itself can either upregulate, activate, or inhibit its own metabolism, so that we get some feed forward that is going to change dynamically what is going on in the pharmacokinetics. The metabolites that are produced out of this can also feed back and either inhibit or enhance that whole process. And to really complicate matters, you could also have a separate medication. How many patients do you have who are only on one medication? So as soon as we get a second medication, there's the potential for that medication to have its own influence on those metabolic processes and either enhance or inhibit the whole shebang. So this immediately gets very complex, and this is one of the challenges that we have been faced in this area, is trying to work out how to sift through this to come up with the useful messages that I alluded to in the preceding slide. So I want to give you an example of pharmacogenetics in the management of depression, and we'll see how well we're doing in that particular space. You'll be very familiar that a major depressive disorder is common. There are some facts and figures about its prevalence, about the time taken to achieve a response or remission. It's a prolonged trial and error approach, and less than 50% of patients with major depressive disorder achieve remission by 12 months. And if you are going to swap from one drug to another, that in itself is a complex process. You need to let them wash out the first drug before you swap to the second, and that transition requires drug-to-drug consideration. Here is a little table from Australian Prescriber from a few years ago with a list of drugs down the first column and a list of drugs across the top row, and it's the intersection of those two gives you the directions as how to swap from one to the other. This is not straightforward prescribing. This is challenging stuff. So it's been one of the key targets for trying to get pharmacogenomics to help manage this. If I take a number of psychotropic drugs and list them not by their mechanism of action, not by the era in which they were introduced, but list them by the genes involved in their metabolism, I end up with a table that looks like this. And the pharmacogenomics is going to, the analysis of the genes across the top row there, is going to help inform our decisions, our prescribing decisions. I want to make it very clear that it does not dictate those decisions, because these genes are only part of the story. We need to consider weight and gender and comorbidities and all those other sorts of things that may be appropriate to do drug levels. All of those things are still appropriate, but here we have some additional information that can potentially help you. Now, let me see how it can. Here's a lovely study that came out of Victoria. It was published a month or so ago, where they had, over a 10-year period, explored the experience of antidepressants of a cohort of patients with major depressive disorder being managed in the community in Victoria. And the left-hand pie chart shows the distribution of different metabolizer types for the two genes that I flagged in the previous slide, two major genes that I flagged in the previous slide, 2D6 and 2C19. Don't worry about the labels, they're just names. And just over half of the patients had what you would regard as normal metabolizer activity, so that they could have standard doses. But the red pie shows those who were poor metabolizers and could potentially run into either lack of efficacy or risk of side effects, depending on how the metabolism for a particular drug went. And the blue guys, people, had overactive, if you will, metabolizer status, who are either at risk of excess toxicity or, in fact, inadequate impact, depending on how a particular drug was metabolized. The key message from this is that there are a lot of people in this study who had gene variants that could potentially compromise the prescribing that they received. The next pie chart in the middle shows the proportion of patients who were having drugs that were concordant with their pharmacogenetic analysis, and about 3/4 of them were. It changed over the course of this 10-year prospective study, but on average, about 3/4 of the patients were on concordant drugs for their genotype. Conversely, about 1/4 of them were taking drugs that did not fit with their underlying genetics. By the way, the doctors prescribing didn't know this. This was a retrospective analysis, so this is no criticism of anyone, but this was just identifying the potential impact of this. And what I found particularly telling from this study is the last slide, which shows over the 10 years, the proportion of patients who were swapping medication. And it's done as a relative thing. Were the patients who were on discordant medications, did they swap more frequently than the patients who were on concordant medications? And the bars above the zero line are the relative rates of drug swapping, if I can put it that way, medication changes in those who are on non-concordant medications. So only 2 of those years with a slight edge in favour of the swapping happening more frequently among those who were on concordant medications. For 8 of the 10 years, it's the non-concordant people, the people in that red sector in the middle of the slide, those were people were swapping medications like it was going out of style. And that is expensive, not just in terms of dollars, but in terms of times, days off work, all those other sorts of things. So this doesn't say that pharmacogenetics could resolve that, but it highlights the potential for this. What we have here is some evidence showing that it can resolve this. And this was a meta-analysis published late last year about 5 randomised controlled trials across 3 different countries looking at the potential for pharmacogenomics to inform prescribing in the community management of depression. They used some common metrics. There was major differences in the populations and how the tests were done and so on, so you're going to expect some heterogeneity, and there certainly was. Over on the right-hand side here, I have the relative rate of remission for those in the pharmacogenomics arm of the trial. And for one of the trials, the top one by Perez, there was in fact no change by adding pharmacogenomics, but for the other four studies that they've looked at, there was a significant advantage in favour of pharmacogenomics, and when you do the meta-analysis and pull them all together, it was 1.7-fold in favour of pharmacogenomically informed prescribing. So there was a 70% better chance that a patient who had PGx-informed prescribing would remit within the period, whether it be 3 or 6 months, of that particular trial. There have since been a couple of other trials published that have confirmed that particular observation. So that's encouraging. We've got evidence of this being potentially relevant. We now have evidence that it really is relevant, but I want to emphasise that this only actually tells you part of the story, because when we compare two cohorts in a randomised controlled trial, as I've summarised here, you've got one group who didn't have the pharmacogenomics included and one group that did. And the difference in the rate of remission between those groups was 1.7-fold in favour of pharmacogenomics. But remember, just over 50%, closer to 60% of the people in the PGx cohort had genotype analyses that you wouldn't do anything different with anyway. They were normal metabolizers. The benefit that we observed in that meta-analysis is driven by the minority of patients who can be taken off their discordant medications and put onto concordant medications. Now that's the real benefit for them, and I'll spare you the details, but you can do some analysis and show that the relative rate of remission for those people with actionable genotypes, where the doctors act on that, is about 4-fold, not 1.7-fold. So that is a very dramatic impact on the care that you're able to provide patients with depression. Look, in terms of the application of this, here is a summary of our the genes down the left-hand side. We offer a panel where we provide information about any medications that you have listed. We describe the analytical result. We then provide a summary table of over 100 medications and their potential significance or changes in prescribing for this particular patient. And then we do provide detailed advice for those particular patients where there is an amber or a red signal. So this is a big report, and we're unapologetic about that. And what it looks, the reason we do that is because this provides you then with ongoing information. In our experience, if you specify certain drugs on the request form, about 20% of the patients will get a report back that says, really, don't use this drug, either because it's dangerous or because, in fact, it's not going to do the patient any good. And about a third had an amber caution on that. And if we look at all of the drugs that are included in this report, about 2/3 have a don't use warning and 74%, so 3/4, had an amber warning. I'm going to skip through this. We do, as I say, this is it's a big report, but it's very straightforward in terms of laying the information before you. And of course, we're very happy to work with you to clarify any of that. We also have we also have tests, let me go back a slide there, on the right-hand side, which are single-purpose tests for particular genes associated with particular hypersensitivity syndromes. So some of these will be more for specialist practice, but if you're prescribing carbamazepine or allopurinol, even thiopurine, then these tests may well be of relevance for you and for your colleagues. Some of those are MBS rebated, most pharmacogenetics is not, and that could be a story for another discussion. So in brief, genetic variations between patients preclude same drug, same dose prescribing. These variants drive the response or indeed the risk of side effects for different patients. The PGx data predicts the metabolism, which informs your prescribing advice but does not dictate it. PGx has been shown to be relevant and effective for prescribing in depression, and there is a large body of evidence across other conditions as well. The PGx report can be read for immediate use and also for long-term use. And for other information, I would direct you to our Sonic Genetics website, where we have a lot of information there. We have genetic pathologists to back up on this, and we can also then provide with specialist prescribing advice should that be required. Thank you.
We will go to questions.
So as a GP, I see patients coming back from psychiatrists, but I haven't seen a single letter yet citing genetic testing as basis for prescribing antidepressants.
And you're right, but that will change. And it's interesting, about 3 years ago now, I worked with the College of Pathologists, and we had representation from a number of the medical colleges, including a number from the College of Psychiatry, where we reviewed the international status of pharmacogenomics and its use in prescribing, and compared that with the situation in Australia. And Australia is woefully behind the 8 ball. In the US, 16% of drugs have a PGx recommendation mandated by the FDA on the drug labelling. There is not one drug in Australia that has that. So there is a major issue in terms of the perception of pharmacogenetics in this country and how it's used. I and others are very keen to rectify that. I'm delighted that the Minister for Health last year announced some specific funding for research into pharmacogenetics and its use in the management of depression. And $7 million worth of research funding has been allocated. I'm glad to say that Sonic is a partner in one of those investigations with an academic department to explore this, because we think not only do we want to add the information to, as it were, the world pool, but we want to increase awareness of the utility of this in the Australian setting. So the evidence is there, but there is a lack of awareness, hence my soapbox.
Does anybody else have a question? I'm pretending to be Steve.
That's a very interesting talk that you've given there, Professor. So my question relates to the fact that, you said that in an individual, you're not sure of the actual response once the actual drug's been given. Are there any further tests to determine the individual response within an individual related to a medication that they're on long term? And if so, what are those tests available these days?
Yeah, so look, it's a really good question. To what extent can other tests be used to help inform the prescribing advice that you're using for a particular patient? Now, I've emphasised that pharmacogenomics is only one of the data elements, if you will, that you can use for this. You also need to factor in the things that clinically you do already, like age and gender and renal function, liver function, and so on. We can also begin to use therapeutic drug monitoring, and Sonic provides monitoring for many of these medications. We can also access more extensive monitoring from other laboratories. There's increasing interest in integrating those drug levels with a model of the physiology of the patient and their pharmacogenomics. And in that way, you start with a physiological model of the average patient who is female and weighs 75 kilos and is 85 years old, or whatever the numbers might be. So there'll be a normal spot. And then you can add in the drug levels that you're taking over time and refine that physiological model of the patient against those drug levels. So these things are coming. That type of modelling of dose against how the body is actually handling the drug is now well established for gentamicin prescribing in some hospitals within Australia and certainly overseas. And so it certainly has great potential. I think the real magic will come when we do integrate the pharmacogenomics and these Bayesian models, as they're called, to refine the precision dosing for a particular patient. So I think what we've got with pharmacogenomics at the moment, on the one hand, I think it has been overhyped in some circles overseas. It's been underutilised in other areas, such as in Australia, and it is still at its early stage. So if I could say to everybody, don't do any prescribing for the next 10 years, come back when we've got the information and we can help you out with this better, then that would be a really nice way to do it. But the reality is we can't. We have to deal with the information that we've got at the moment. So what I've presented to you today is a 2020 approach to pharmacogenomics. It will and it must change to address the very possibilities that you've raised.
Any more questions? Oh, yeah.
Thank you for that. I've got two questions.
Well, you'll have to pay extra for that, but that's all right.
One is there any sort of insurance repercussions with these sort of tests, like with the other genetic tests? And also, is there any current trials at the moment that we could access this without that cost to the patient?
Yeah. So the first question about the insurance risk, there should be no insurance implications from a pharmacogenomics test. And the reason I say that is at the moment, if we just reduce it to a binary choice, I've got drug A or drug B, and on clinical grounds I have no reason to preference one over the other. What pharmacogenomics is doing is helping to provide that preference and to point towards a lower risk, higher return. But both drug A and B have already been approved for use in this setting. They're on the PBS or whatever. So from an insurance point of view, I really cannot see any basis on which that constitutes a hazard for the insurability of a patient. You'll notice that I said I cannot see. The world of litigation is not necessarily one that's readily predicted. And I'm not aware, by the way, of any argument to the contrary being made at the moment. The second thing is with regard to trials, I'm not aware of any trials in South Australia for this. The trial that Sonic is involved in is based in Victoria, and they had the particular Department of General Practice that we're working with had a very good framework to work with that. I know that there are other trials happening within New South Wales and possibly in Queensland, but I'm not aware of any in South Australia yet. Having said that, there are some good people in pharmacogenetics in South Australia, and I'd be very keen to work with them to see if we could do such a trial for the very reasons that you've mentioned. At the moment, we estimate that there are about 1.7 million Australians taking drugs for which current PGx advice would be pertinent every year. When we look at the top 10 genes, the top 30 drugs for which there is very good high-level internationally recognised evidence for the basis of this advice, we find that there are only 2 tests available on the MBS in relation to this. One for Abaca-VS hypersensitivity and the other for the thiopurine sensitivity, the TPMT assay. None of the other tests are currently rebated. So I think that is of concern. I think it sort of echoes the point I made to the first questioner here, that we just don't have that level of awareness and engagement yet, and I hope that will change over the time. At the moment, our panel test costs just under $200. I recognise that's $200, but if we think in terms of that providing a net 70% benefit in the rate of remission for a condition like major depressive disorder, then that's actually not very much, even at the individual level, when you think of the indirect costs that they're having to carry. Madam Chair, how are we going for time?
I think that's it. We'll move on to the next topic.
We'll move on to the next topic. Sorry, guys. Look, by the way, my contact details are on the presentation in front of you. I'm very happy to receive emails from healthcare professionals inquiring about this. So if you do have any questions, please feel free to ask. And also you can speak to the people at ClinPath. We have Jill Hall, who is the genetics product specialist, so she's got particular expertise in this space. Jill is here this afternoon if you'd like to touch base with her, and she can also help with the logistics, the practicalities of getting the testing done as well. Thank you.